Vishal, I think we are ready to start.
Yes, ma'am. Kaushik, can we go live?
Yeah, it's already live, no?
We are live now.
Okay. Thanks a lot, Kaushik. We'll just wait for another 2 or 3 minutes so that others join, and then we'll start the proceedings. Maybe another couple of minutes, and then we start off. Good evening, everyone, and welcome to this session of Advanced Pediatric Neurology Lecture Series. And today we have a much sought after topic. In fact, this topic was in high demand for quite a long time on newer anti-seizure medications. And we have an absolutely star-studded evening today. The session will be moderated by Dr. Vinyan, and the speaker for today is Dr. Sanjeev. Dr. Vinyan is, Kaushik, can we have the next slide? Dr. Vinyan is the prof and head of Department of Pediatric Neurology at Amrita Institute of Medical Sciences. He is an active member of International League Against Epilepsy in the Commission for Diagnostic Methods and a member for Neonatal Seizures and Research Advocacy Task Forces of ILA. He's also a convener for Pediatric Neurology subsection of Indian Academy of Neurology, a treasurer for Indian Epilepsy Society, and a member of National Governing Council of Indian Epilepsy Association. So thanks a lot for agreeing for chairing this session. Over to you, sir.
Yeah, thank you, Vishal, for inviting me here for this day. And then it is my proud privilege to be a moderator on this evening with Dr. Sanjeev Kothari, who doesn't need an introduction. We have all seen his works in more than 250 articles in many major international journals and different aspects of epilepsy, especially in epilepsy in children. He is currently the professor of neurology and pediatrics at the Donald and Barbara Zucker School of Medicine at Cohen Children's Medical Center in New York. And he had his training in pediatric neurology at Massachusetts General Hospital in Boston, and then after that he had further training in epilepsy and sleep medicine at Duke, and he has been faculty at Harvard Medical Center earlier, and then he has been a professor of neurology and pediatrics at NYU. Currently, from 2017, he is at the Cohen Children's, and I think there's, as far as the topic is concerned, we don't have to be a little, there are a lot of interest, especially with a lot of new drugs, but especially from the pediatric point of view, I don't know whether we have the what we want, actually. We have a lot of new drugs, but whether many of our patients, the children with complex epilepsies are getting the real treatment or the treatment over these years. That's the real issue here. But with this introduction, I will pass on my mic to Sanjeev. So you can take it over, and then we are waiting for your show.
Thank you very much. Let me share my screen. All right. Can you guys see?
Yeah,
Yes,
perfect.
yes, perfect.
All right. So thank you very much for inviting me. And I thought I would structure this talk in a little different way rather than going drug by drug, give you an overview of how to use these drugs from using their mechanism of actions. So I have no conflict of interest for this talk. Here are my learning objectives: to be knowledgeable on availability of new anti-seizure medications, to be aware of the mechanism of actions of these newer anti-seizure medications, to be able to know their clinical indications in various epilepsy syndromes, and to be aware of designer drugs, precision drugs for various epilepsy syndromes in the near future. So I want to first start off with this article that came in Epilepsy in 2010, where they changed the definition of epilepsy. So in the past, epilepsy used to be 2 or more unprovoked seizures. They changed that to 1 unprovoked seizure with either an abnormal neurological exam, an abnormal EEG, or an abnormal MRI finding to be defined as epilepsy. Why did they do that? Because the chances of having a second unprovoked seizure with these criteria is more than 60%. And so therefore, why delay treatment? So that's the new definition of epilepsy. And then they also defined that how do we say that you're now in remission? So one was if you have an age-related epilepsy syndrome, which was benign, for example, benign Rolandic epilepsy that goes into remission by 13, or benign occipital lobe epilepsy, which goes into remission within 2 years of onset of the seizures, or those who have remained seizure-free for the last 10 years with no seizure medication for the past past 5 years is considered seizure freedom. I also wanted to point you to the 2017 definition, which completely changed the picture of how we classify epilepsy. This is the 2 articles. One is the ILE classification, and the second one is the AES counterpart of it. And I've given you the references over there. But basically what it means is that, the old definition of seizure types, focal, generalized, and unknown, remains. But they've added now epilepsy types, which is focal, generalized, combined focal and generalized, and unknown. And then finally, they have stressed a lot on epilepsy syndromes, because epilepsy syndrome is what really gives you the natural history, the prognosis, what drugs to use, how to counsel your families, etc. And that's why they have really, really stressed on the epilepsy syndromes. They've also emphasized the comorbidities which can exist with it, like psychiatric comorbidities like depression, anxiety, sleep comorbidities like obstructive sleep apnea, obesity, and other problems. And finally, they have really emphasized that you need to go to the etiology. So is this epilepsy caused because of a structural abnormality seen on the MRI, a genetic abnormality seen, or infectious pathology, metabolic conditions, immunological conditions like autoimmune encephalitis, and if it's unknown. So I think this is the classification which I really think people should be using in their discussion with the families, as well as documenting in the electronic medical record. And then they further went on to subclassify it. So focal, generalized, and unknown. Now focal, they removed that word simple and complex partial and put it preserved awareness and impaired awareness. That's how they divided it. And it was motor and non-motor. And they removed the secondary generalized to focal to bilateral tonic-clonic. So this is the new terminology. And then this is again further divided into automatism, atonic, clonic, epileptic spasms, hyperkinetic, myoclonic, and tonic. And then the non-motor would be autonomic, behavioral arrest, cognitive, emotional, and sensory. And then this is similar for the unknown, unclassified. And then in the generalized, they had tonic-clonic, tonic-clonic, myoclonic, myoclonic, tonic-clonic, myoclonic, atonic, atonic, and epileptic spasms. And in the absence, it was typical, atypical, myoclonia, and island myoclonia. And then obviously, as everything happens in life, you have an opinion from the left side and opinion from the right side. So therefore, these are the 2 pros and cons of this classification. So the proponents, including Jackie French, my colleague and friend from NYU, wrote this big thing why we should use this, because basically it streamlines the way we classify and document epilepsy across the whole world, so that then big data sets can be shared for getting more epidemiological data. On the opposite side, Dr. Hans Luder from Cleveland said, this is too complicated. We are used to an old classification, which is in our memory. Why do this changes? Blah, blah, blah. It is complicated. So, you have these 2 things going across. But please have a look into these 2 articles. They're interesting. And then this is a big laundry list of all the drugs that we have. In general, you know, the Quanon-Brody study where you have any epilepsy, any seizure, you first try the most common monotherapy. There's a 46% chance that you'll go into, you'll have a response. If the first doesn't work, use an alternate monotherapy, and that goes up to 60% with the efficacy. And then you go on to add-on therapies, and that may bring it up to 70% at best. But beyond that, you have to think of ketogenic diet, VNS, RNS, and many other options. And then I'm not going to give you all this thing. Is there in, I've sent a PDF of my talk. So please, you can share those, you can go through the various options available for various epilepsy syndromes. And we will talk a little bit more on some of these rarer ones over here. So this is the laundry list of all the drugs available. Now, the most important thing I would like to emphasize is why should you not call this as anti-convulsive drugs or anti-epileptic drugs? The reason is because they're really truly not anti-epileptic. Epileptogenesis is not prevented by them. They're anti-seizure medication. They just prevent seizures. They don't prevent epilepsy. So therefore, I think the word terminology anti-seizure medication should be now applied across board. Stop using the word AED, you use ASM. And second thing is you can have anti-convulsant is not good because you can have non-convulsive seizures too. Therefore, ASM is the new definition for anti-seizure medications for epilepsy. And then this is the laundry list of all the drugs that were available. So remember in the 1800s, bromides were used first in dogs and then used in humans. Then came phenobarb in 1910. And then came the first generation drugs in the 60s, including your ethosuximide, and then after that, the second generation came on with these drugs over here, and then in between 1994 and 2000, I would say 7, the third, or even 2010, the third generation drugs came out, and then finally, the fourth generation, which is very specific for our pediatric epilepsy, fenfluramine, cenobamate, cannabinol, CBD, and everolimus and brevacitap. So these are some of the fourth generation drugs. I would say that they are fourth generation because they have a higher efficacy than any of the other drugs so far. So the big question that is asked over here is, and Jackie French, who used to have office right next to us at NYU, always puts this point. Are these new anti-seizure medications better that we have developed over the last 30 years? And the answer is probably no, except for the fourth generations. Almost all of them have the same efficacy as the old anti-seizure medications. But the advantage with them is that they are more lipophilic and therefore they penetrate the brain faster. They have less drug interactions. They have a longer half-life, so they can be used once a day. They have fewer side effects and hence are better tolerated. I think this is the most important thing. They are better tolerated because of fewer side effects. Their efficacy remains similar to the first and second generation drugs. So let's talk a little bit about receptors to understand anti-seizure medications. So I'm going to start with first the sodium channel. And in general, the neuron has the resting state at -70 microvolts. Then it goes through a depolarization phase because of the sodium influx, and then a repolarization phase because of potassium efflux. And then it goes into a refractory stage, and it comes back again to resting state. This firing of neurons causes the depolarization, which causes neurons to fire and have seizures. And so this is basically the resting state, the activated stage, and the inactivated stage. Now, the inactivation happens because of slow inactivation and fast inactivation. And in general, the sodium channel receptor has 4 domains, and each of the domain has 6 helical units. And the first 4 are thermal receptors. The 5th and 6th are where there is a pore for the sodium to go in. So over here, if you look at this, in the resting state, the gate is closed. And so therefore sodium cannot come into the cell. When it opens up in this activated stage, there is a rapid influx of sodium into the cell, which makes it positive. And then after the immediate rapid depolarization, the rapid or the fast inactivating gate closes to to decrease sodium influx. And then a slow inactivation happens to close the gate a second time. And then the gate is closed. At the same time, potassium is getting out of the cell. And that overall leads to this inactivated stage. And then it goes back again to the resting stage. So this is very important to understand how epilepsy is propagated and where the drugs will work. There's also something known as a persistent sodium current, which I will talk to you as we move on. So what happens in this persistent sodium current is, in spite of depolarization and the gates being closed, there's a little bit of a gate, a separate gate, which remains open, causing persistent depolarization. And you will see that this happens more with drug-resistant epilepsy. And obviously, there are two drugs which have come out, which act only on the persistent sodium current, which is lacosamide and eslicarbazine. And so this, please understand this, because this is going to be the entire foundation of my talk. Similarly, you have a potassium channel. Now, the potassium channel, again, is very similar, 6 domains. Each of them, the important thing is that it doesn't have an inactivation gate. It basically remains closed. And once there is complete depolarization, it opens up and potassium goes out. When the potassium goes out and the sodium influx is stopped, at some point, there is an equilibrium established, and that closes the potassium gate automatically, or not. There's no gate. It just doesn't allow more potassium to go out. So therefore, slow repolarization as the voltage gate eventually closes. There's no inactivation gate. And there is this M channel, which basically raises the threshold for depolarization by counteracting sodium influx. This is open at rest and more opens with depolarization and results in slow depolarization. And this may be an action, mechanism of action for a new drug, which will be in the pipeline. The older one was izogabine or Potiga, which has been taken off the market. Then you talk about the GABA receptors. So you have 2 alpha, 2 beta, and 1 gamma receptors. And basically, this is the GABA receptor, which allows the chloride to go into the cell through this pore over here in the middle. So this is the GABA receptor. And then this is very important. This is the serotonin receptor. So basically, in the presynaptic neuron, the tryptophan gets converted to serotonin, and the serotonin then goes out of the cell and attaches itself to the postsynaptic membrane, which then positively modulates the GABA receptors with increased inhibitory effects on the seizures. Obviously, this serotonin gets uptaken into the neuron and gets finally destroyed through a calcium-dependent exocytosis. So this is the serotonin receptor, which is the mechanism of action for Fintepla or fenfluramine. I just thought I'd put it over here. Question is, and everybody, in the past was, you have a Dravet syndrome, sodium channel. How does a serotonin receptor work over there? This is how it works. It increases the GABA activity in the sodium-dependent neuron and therefore decreases seizures through the serotonin GABA modulation. So now that you know what the few receptors are, let's talk about the mechanism of actions of these anti-seizure medications. This is a very simplistic way of looking at this. So you have voltage-gated ion channels. So as I showed you, the voltage-gated sodium channel, the calcium channel, the potassium channels, and the drugs have been listed over here. Then you have the GABA receptors. Now remember, all our drugs do not increase GABA. It works as a positive allosteric modulator of GABA, increasing GABA concentration in the presence of GABA. That's very important to understand. And then you have these GABA transporter, which transports the GABA back into the cell. So if you inhibit that, more GABA is present in the synapse. And then you have the GABA transaminase, which destroys the GABA, and that can be blocked by a vigabatrin. And then carbonic anhydrase, which I will talk in a second. There are 4 drugs over here which act on it, and that changes the chloride influx into the cell, and therefore acts in a different mechanism of action. Then we have this new molecule called synaptic vesicle 2A, on which Keppra and Breviact act. And then we have this alpha-2 delta subunit, on which gabapentin, pregabalin, and gabapentin anacapital works. Then you have an AMPA receptor where perampanel works. And then you have these are truly disease-modifying drugs. This one works on the mTOR pathway, which is everolimus. And the other one is a lysosomal enzyme replacement drug, which works on the NCL, neuronal ceroid lipofuscinosis. And then we have other drugs which have no mechanism of action that we know of. And this is a much more complicated way of looking at it. So as I showed you, if you increase the fast inactivation pathway, so that's your conventional sodium channel drugs. If you increase the slow inactivation, that's your lacosamide and estricarbazine. And if you block the persistent channel, that's cenobamate. And that's the reason why cenobamate is so great. It's in use in adults with focal epilepsy, but we are using it now even for pediatric epilepsy. And it's just an amazing drug. Now, the voltage blockade of the calcium, the T subtype, the transient subtype channel, high voltage activated is your standard drugs, but your low voltage activated T cells are your ethosuximide. And then there are others which are not that important. Maybe valproic acid may work over here. And there's some recent data that even Breviac might work over here. Potassium channel, we had this drug called ezogabine, which was taken off the market because of purple skin, nails, and mucosal membranes. But a new drug is out in the pipeline using a similar mechanism without having the side effect profile. And then, as I mentioned, the GABA-mediated inhibition, they are called positive allosteric modulators of GABA receptors. They are not actually GABA drugs, they're modulators. And you have the conventional drugs over here. As I showed you, the transporter inhibition is ticagrelin. The transaminase inhibitor is vigabatrin, and then activators of GAD is possibly valproic acid. And the NMDA receptors are felbamate. Topiramate has a kinase blocking mechanism. AMPA is verapamil. SV2A is Keppra and Breviac. And then I mentioned the other ones. And so this is a much more complex way of looking at it. This is the third way of looking at it. This shows you receptor by receptor where it works, the inhibitory synapse and the excitatory synapse. And it shows you where these various drugs work on, very similar to what I've spoken to you. So now, why does drug-resistant epilepsy happen? That's very important to know because we have drugs which work, and then after some time, they stop working. So that's why it's important to know what's the mechanism of action of drug-resistant epilepsy. And basically, it has 4 ways that it can lead to drug resistance. Number 1, so this is the nucleosome, and this is the acetyl group. So you can have the histone deacetylation of this nucleosome, which down-modulates the gene expression of benzo GABA subunit and calcium impermeable AMPA receptors. So that's one mechanism where basically through histone deacetylation, you have drug resistance. Second mechanism is through differential DNA methylation. When the DNA gets methylated, these methyl groups, it doesn't allow the drugs to work. And what happens because of that is that thousands of coding and non-coding regions, including those associated with protein expression and signaling pathways, inflammation, among others, are inhibited. And then the third one is the mRNA, the microRNA and the mRNA. The non-coding mRNA overexpression has been associated with cell damage, oxidative stress, proconvulsant effects, impairing GABA synapses and increasing sodium currents. So there we go, the sodium currents come there. And finally, this restrictive, what we call as a REST/NRSF, there is a change in the protein expression with this fourth mechanism, and that mainly affects the BDNF ionic channels, the glutaminergic receptors, etc. And so this 4 mechanisms is why drug-resistant epilepsy could be happening, and this is called epigenetics. Epigenetics regulates gene expression or function without changing in the DNA sequence itself. That's the mechanism of drug-resistant epilepsy. One more way to look at drug-resistant epilepsy is to see, so on the positives, on the left side over here, you have drug-responsive epilepsy where there are various channels, the drugs act on it, everything is great. With time, these receptors get modulated or modified, and then the drug doesn't work well. So that's the mechanism. And one of the mechanisms to explain that would be that the specific receptor gets changed into what is called as heteroreceptor. And this heteroreceptor gives you excitatory effects where the drugs don't work. So this is another way of looking at why drug-resistant epilepsy happens. All right. With that, I'm going to open up the next part, which is the 4th generation anti-seizure medications. So let's first talk about stiripentol. Stiripentol has been there in Europe for a long time. The French have used it very successfully for Dravet. It just came in the market in the USA about 2 years ago. So it works in Dravet syndrome by enhancing GABA neurotransmission by increasing duration of GABA receptor channel opening and interfering with GABA reuptake and metabolism. So we use it at 50 milligram per kilogram per day in 2 or 3 divided doses. And it has to be used along with valproic acid and clobazam. And the responder rate was amazingly 71% for tonic-clonic and tonic seizures in Dravet syndrome. It also reduced the status epilepticus seen in these patients. The main side effects were anorexia, sedation, and dizziness. And unfortunately, it's a very dirty drug. It has many drug interactions. So we have to keep on doing drug levels, especially clobazam levels and other anti-seizure medication drugs levels. Next, Epidiolex or CBD. How does it work? First of all, it does not work on CBD receptors. Only THC works on CBD receptors. We thought initially that maybe CBD works on CBD receptors 1 and 2. No, CBD 1 and 2 receptors are modulated with THC, not with CBD itself. So it acts via G protein coupled receptor, what is called a GPR55 antagonism, reducing hyperexcitability. It also modulates the adenosine reuptake via equilibrative nucleoside transporter 1 called ENT1. It desensitizes transient receptor potential cation channels, the TRPV1, and finally, it enhances GABAergic neurotransmission. So you can see it has multiple mechanisms of actions, and it works pretty well. So this is approved for use in the US for Dravet syndrome about 2 years of age as an add-on therapy, but is also approved for Lennox-Gastaut and tuberous sclerosis in a dose of about 10 to 20 milligram per kilogram per day. The median reduction in seizure frequency is around 50%, and it's effective for all type of seizures, including tonic-clonic and drop attacks. The main side effects with this drug, remember this drug is available in a oil-based liquid, and the oil is sesame oil. So therefore, because of that excessive sesame oil, you get anorexia, diarrhea. You can get elevated liver transaminases, which is more seen with valproic acid polytherapy. Sedation, the sedation is directly by CBD or via increasing the desmethylclobazam levels, which is often used along with it. And this is available as 100 milligram per ml in a sesame oil. And to date, no tolerance has been documented on long-term use. So this is a great drug. We have been using it very effectively for both LGS, tuberous sclerosis, and Dravet syndrome. Next, moving on to Fintepla or fenfluramine. This is an amphetamine derivative, and it possibly works on the 5-hydroxytryptamine 5-HT1D, 2C, and possibly 2A receptor agonism. But it also has been found to have a sigma-1 receptor antagonism. This is a new receptor, sigma-1, and this they believe may be actually giving you not only seizure control, but better cognitive outcomes. So the 5-hydroxy agonistic activity enhances, as I showed you in my serotonin slide, GABA transmission and decreasing seizure. The sigma-1 receptor, as I mentioned, is an opioid type of receptor, which improves cognition and learning, and also has a weak anti-seizure activity via release of neurosteroids. Neurosteroids also modulate the GABA receptors. So that's the second way it works. So therefore, this drug is approved for use in Dravet syndrome for ages more than 2 years. Standard doses, remember, fenfluramine was released in the USA in the 90s, like 1998 or 99 for obesity control, but the doses used were 200 milligrams. The doses now that are approved is 0.7 milligram per kilogram per day in 2 divided doses, which in an adult translates to 26 milligram max. So we are using almost 10% of what was approved for obesity in the past. And why was that done? Because the drug was pulled out from the market because of cardiac toxicity. With this low dose, there has been not a single case with cardiac toxicity that we have seen in the past 2 years. And in Belgium, not even a single case of the last 20 years that they've been using it over there. So therefore, it's used as an adjunctive therapy for Dravet at 0.7 milligram per kilogram per day. When you use it in combination with clobazam and stiripentol, the dose is reduced to 0.4 milligram per kilogram per day, because stiripentol has a drug interaction with fenfluramine, and it decreases the metabolism of fenfluramine. Therefore, a lower dose has to be used. Amazing. Median reduction in seizure frequency was 74%, and the responder rate was 68%, with 8% achieving seizure freedom. No drug so far has ever done this kind of a thing. Side effects include sedation, of course, because it's an anti-obesity drug, so decrease appetite, weight loss, sedation, diarrhea, and fatigue. So in the US, it has a REMS program. REMS is basically a mitigation program because of its side effect profile that is monitored federally, so that there is no risk of death from overuse or not properly being used. So there's a REMS program which needs a 2D echo documenting absence of valvular heart disease or pulmonary artery hypertension at baseline, at 3 months on the drug, and every 6 months. So far, as I mentioned before, no positive cases have been observed. It is getting approval for LGS. However, it is a little disappointing that in LGS, the median reduction in seizure frequency was 26%, but 50% on tonic-clonic seizures, which is what causes the biggest morbidity and mortality. So obviously it does very well in 50% on this type of seizure types. And therefore it's also being tried for other indications like CDKL5, PCDH19, and other monogenic epilepsy syndromes. And importantly, we published a paper over here just recently that when fenfluramine is used in Dravet syndrome, as you know, Dravet syndrome has a high risk of SUDEP, almost 1%, 1 in 100. That SUDEP risk was reduced tenfold, so that the risk is now 1 in 1,000, very similar to general epilepsy with SUDEP risk. So therefore, it's a great drug. So what I do in my practice, I try to use, in the past, I used to use SSRI like Prozac or Zoloft to augment the anti-seizure medication mechanisms and also prevent SUDEP. Now that I have Fintepla available for me, I combine Fintepla with anti-seizure medications, even though in LGS, its median reduction is only 26% because of its anti-SUDEP protection role. So next, last one is cenobamate. So cenobamate is, which is called Xcopri in the US. This preferentially inhibits the persistent sodium channel that causes slow depolarization in the inactivated state. As I mentioned to you, this persistent sodium channel is very important for drug-resistant epilepsy. The epileptogenesis somehow induces this slow depolarization even in the inactivated state, and that causes drug resistance. But this drug acts on that sodium current. Therefore, it is so effective. It inhibits but it also inhibits the slow voltage-gated sodium currents in a dose-dependent manner, thus shifting these cells towards hyperpolarization and also increases the action potential threshold needed to overcome this state. It also has a GABAergic mechanism, and it shows a positive affinity for a GABA receptor at a site independent of the benzodiazepine receptor site, and it enhances tonic phase currents inhibition in the hippocampal neurons. So it has a dual mechanism, the sodium channel and the GABAergic mechanism, and that's why it may work both in partial and generalized epilepsy. This is approved for use as an adjunctive therapy for focal epilepsy in adults more than 18 years of age. We are using it in pediatric ages, and we have a paper that's just going to be released on our experience with the first 25 patients in children with very good efficacy data. So you start this drug at 12.5 milligram once a day at night, and it is gradually escalated every 2 weeks up to 200 milligrams. 12.5, 25, 50, 100, and 150, and finally 200 milligrams. This is done to prevent DRESS syndrome. If you go fast, you'll get eosinophilic DRESS syndrome similar to lamotrigine. And it has a better efficacy if you can increase the dose to 400 milligrams, but you get a more side effect profile at higher doses. The median reduction in seizure frequency was 64%, and the responder rate was 68% at 200 milligrams and up to 80% at 400 milligrams. So no drugs has ever had 80% efficacy. And remember, this drug is added on to at least 5 other anti-seizure medications. So therefore, you can imagine if it was used as first line, it probably would have 100% efficacy. The seizure freedom is seen in 20% as an adjunctive therapy on top of 5 other drugs, and up to 60% continue to use it. The retention rate was 60% when followed for 4 years. So it's well tolerated if you use it correctly. Now, the problem is, it's again, unfortunately, even though it's a 4th generation drug, it is a dirty drug. It has a lot of drug interactions, similar to felbamate. So it decreases the concentration of lamotrigine and carbamazepine and tegretol when you start using it. Increased concentration of phenobarb, phenytoin, lacosamide, and desmethylclobazam are seen on cenobamate. So these drugs have to be lowered. And this is one of the reasons why patients stop using it, because as you introduce cenobamate, and if you're on lacosamide dose has to be reduced prophylactically. Otherwise, you get a lot of sedation, dizziness, and you stop taking the drug. So we have been very cautious now that if you're on phenobarb, phenytoin, lacosamide, or clobazam, you have to drop these drugs down as we introduce cenobamate, because these concentration of these drugs go up. Now, cenobamate concentration may be reduced by phenytoin, but be increased by clobazam. So it's got a bilateral drug interaction, both two ways. So just be aware of this drug interaction. Side effects include DRESS syndrome, diplopia, dizziness, sedation, weight loss, anorexia, and nausea. And you have to go slow. And if this is getting approval for primary generalized epilepsy and maybe in the future for LGS, I think this is a great drug in the armamentarium. I know that you guys don't have it in India, but I'm sure it will come up very soon. And then let's talk about what is called as precision medicine or designer drugs. Treatment and prevention approach based on understanding of individual variability in genetic architecture, environment, and lifestyle. That's the definition of precision medicine. And that's going to be the future. So what are the drugs available in the pipeline? So patsovanil, which is a drug in phase 2 drug trials, is approved for focal epilepsy, and it works both on the SV2, which is the Keppra-Previac mechanism, and the GABA-A. So it's dual now. So that's why it has a better potential for better efficacy. Ganaxolone has been in the market. It was withdrawn and then is back again. It's in phase 2 and 3 studies for CDKL5, PCDH19, and catamenial epilepsy. Again, this and also for status epilepticus. And it acts via release of neurosteroids. Neurosteroids modulate the GABA receptors, and therefore it works through a different mechanism. Now, you know that as I showed you, the GABA receptor, the alpha subunit, has 1, 2, 3, 4, 5, and 6 subtypes. The 1 is sedating. That's where all your zolpidem and Ambien and Sonata and Lunesta, they work. But we don't want 1 because that causes sedation. So if we can take away 1 and just use 2, 3, and 5, you would have a much better seizure efficacy. Now, clobazam is called Onfi in the US because it's 1 and 5. This is even better. It is 2, 3, and 5. And so therefore, it probably will be much more effective in epilepsy as an add-on therapy without having the sedation side effects. So that's CVL 865, which is in phase 2. The other one is CX8998, which is in phase 2 trials. We're going to be working on absence because it is going to modulate the T-type calcium channel blocker similar to ethosuximide, but in a much more efficacious manner. So that's another drug. And then I've already spoken to you about fenfluramine. There's a product called clemizone, which is even more specific, again, the 5-hydroxytryptamine receptor, which is in the pipeline and should be out in the next 2 years. So that's. And then CEN 1101, this is one which we are looking forward to. It's already going into phase 3 now. It opens the potassium channel without having the side effects like ezogabine causing the purple skin mucosal syndrome. So this is available for us right now in the US on a compassionate basis. And then TAC935 is another very promising mechanism. So what it does is that in general, cholesterol works. Cholesterol is metabolized to 25-hydroxycholesterol. 25-hydroxycholesterol acts on the NMDA receptor as an excitatory mechanism. So you want less 25-hydroxycholesterol. So if you can inhibit cholesterol metabolism by using 25-hydroxy cholesterol hydrolase inhibitor, you'll get less of 25-hydroxycholesterol and less NMDA activity, and therefore better seizure control. So it's being now getting approval for various monogenic epilepsy syndrome, including DUP15Q and CDKL5. Cenobamate, we have already spoken for. I'm not going to discuss. Atalurin is another great drug, which is being now in phase 2 trials for Dravet syndrome and CDKL5. So it acts via the antisense nucleotides. And I'm going to talk about that in a minute, about what these antisense nucleotides, oligonucleotides are. You are aware that this for SMA, we used a similar technology, the ASO technology for risdiplam, where these are ASOs. And so they are going to be used, similar technology is going to be used with atalurin for Dravet. And then this trial just got completed, the natalizumab, which we use for MS and other autoimmune encephalitis. It is now getting slow approval for focal epilepsy. It acts on the alpha-4 integrin, which is the endothelium connecting the blood-brain barrier. So if you can stabilize that, you'll get less cytokines going into the brain and setting a cytokine storm. So that's its mechanism of action. Finally, in NORC and FIRES, we are using anakinra, which is an interleukin-1 antagonist, and tocilizumab, which is IL-6 antagonist with very good efficacy. We have a paper that's coming out on this, on the efficacy of these drugs in NORC and FIRES. And this is another way of looking at the same thing, that you can target it through multiple mechanisms, which I've just told you, either increasing the GABA inhibitory or decreasing the excitatory subcomponents. And so with that, I want to introduce 2 new mechanisms of actions. So I'll talk about adenosine first. Now, adenosine, you know that caffeine antagonizes adenosine. Now, adenosine is of interest to me because I do both sleep medicine and epilepsy. So from sleep perspective, when you're awake for the whole day, your adenosine levels goes down. And when you sleep, that adenosine precipitately drops. Now, this, if you apply to epilepsy, we feel that if the adenosine suddenly drops as you fall asleep, and that's why maybe epilepsy is triggered at the onset of sleep. So that's the adenosine mechanism of action to explain why seizures happen as you are falling asleep. Now, if you look at it from a different perspective, so whenever there's a big seizure, there is a lot of adenosine that suddenly is released in the synaptic cleft. By the way, adenosine lives in the astroglia. It does not live in the neurons, but it is in the synaptic cleft. Now, when you have a sudden seizure, adenosine is released, and when adenosine is released, there is an attempt to decrease seizures. But what happens with time is that adenosine is normally metabolized to AMP by adenosine kinase. So so with time, with epileptogenesis, this adenosine kinase keeps on increasing in the astroglial regions, causes astrogliosis, and that causes drug-resistant epilepsy. So therefore, if you can do adenosine kinase inhibitor, you can increase adenosine in the synaptic cleft. So that's a different mechanism of action that's going to be coming out soon, where ADK antagonists will be useful to decrease adenosine in the synaptic cleft, because adenosine is connected to ATP, and adenosine receptors are there both in the hippocampus and in the brainstem, and therefore you can improve epileptogenesis as well as decrease or continue breathing or decrease apneas that happen with seizures. So it's a very important molecule, and stay attuned to this drug mechanism of action coming in the future. So that's a different mechanism of action, which I think is very promising. And then other one is orexin. So orexin is a neuron. Orexinergic neurons are present in the lateral hypothalamus, and there are about only 75,000 orexinergic neurons in the lateral hypothalamus. They basically modulate the entire brain, keeping the person awake. Now, you know that in narcolepsy, these orexin neurons die. Once they die, your entire alertic system is gone. You get sleepiness, but more importantly, orexin modulates REM sleep. So you know that in narcolepsy, REM sleep rebounds or is in tremendous, and you know that REM sleep is anti or seizure protective. So therefore, if you use an orexin antagonist in a non-narcoleptic and who has epilepsy, you will increase REM. If you can increase REM, you can have decreased seizures. So this is a different mechanism of action which is being looked into, the orexin pathway to control epilepsy. With that, I'm going to just give you a few additional tips about neonatal and infantile epilepsies. This is nothing to do with seizures, but just some new concepts. So for example, there was a trial done in Lancet Neurology, multicentric trial, which looked at combining ACTH or prednisone with vigabatrin. And they found that by doing that, the spasms reduced faster and there was a better outcome. So it's something which is being looked into. Can you combine prednisone or ACTH with vigabatrin? And this was a follow-up study a year later, and they found even though this, the overall outcomes were similar, if you can control your spasms earlier, the chances of having developmental outcomes are better. And so therefore, this is a positive study that it does improve the outcome if you combine the two. However, there are side effects when you do a combination therapy. So just be aware about that. So in the future, we will be using antisense oligonucleotides. This is what we call as ASO, which is the mechanism for Spinraza and everolimus. I'm sorry, excuse me, Evrysdi, which is Spinraza is given intrathecally, and Evrysdi is given or risdiplam is given orally, and these are using the same antisense oligonucleotides which regulate the mRNA transcription. The problem is that in SMA, Spinraza and all these, and it can be given because it's a peripheral mechanism, but this is a central mechanism. So you need an ASO, which either should be given intrathecally or via reservoirs in the brain itself. To offset that problem, you can use small molecules that induce translational read-through suppressing stop codons and results in full synthesis of proteins. Because they are small molecules, they can penetrate the blood-brain barrier. And then Zolgensma was used in SMA using this technology, the adeno-associated viral vectors, with a promoter and a target gene to replace the abnormal gene. But problem with this is that the Dravet's SNA, sodium channel 1A gene, is big. You can't use this. So you may have to use CRISPR technology to break that genetic into a smaller profile and then introduce it. But it has to go in the brain. So you may have to use it intrathecally. So using either AAV or CRISPR technology, we may be able to completely cure these conditions. So these are some things in the future that are there in the pipeline. And then a few words about neonatal seizures. I want to emphasize, and some of you are here who are part of the ILA, so you're aware about the neonatal seizures. The whole thing about neonatal seizure classification has changed. Basically, you classify them as acute provoked seizures and epilepsies. Acute provocative seizures are usually hypoxic ischemic encephalopathy or infections or metabolic. And then the genetic epilepsies are usually the potassium channel ones, which causes either a self-limiting benign neonatal epilepsy or causes the KCNQ related epilepsy syndrome. So basically classify neonatal seizures as acute provocative seizures or epileptic syndromes. And again, use the same etiological classification: infections, metabolic, genetic, malformations, vascular, and HIE, the big one. And then this was a trial which was done recently where in the neonate, can Keppra be better than phenobarb, because phenobarb has a lot of side effects. And they found in this initial study that it probably was, but in the follow-up study, they found that phenobarb was better than Keppra, but Keppra had lesser side effects. So I think more trials need to be done to see which is a better drug. Lacosamide is always there in the pipeline, so it's worth considering these options. In this paper, what they showed is that after having neonatal seizures, what was the risk of having epilepsy? So they found that 13% of the patients followed up after a neonatal seizures at follow-up developed epilepsy, of which 5% had infantile spasms. Some had discontinued their anti-seizure medications at the time of discharge from the NICU. Others continued for up to 4 months, and there was no difference between the two groups. The median age of onset of epilepsy was about 8 months, and a third of children with epilepsy after neonatal seizures had drug-resistant epilepsy. The risk of developmental delay was 3 times more after neonatal seizures who had epilepsy than those who did not. The risk of epilepsy was more prolonged and of a longer duration with neonatal seizures, number of days with neonatal seizures, and abnormal neurological exam. And we finally confirmed that electrographic neonatal seizures do contribute towards abnormal development outcome at follow-up and should be treated aggressively. I think this is the first time this gave us credibility to the fact that EEG should be done on at least on a 24-hour basis in neonates, because you should be treating the subclinical seizures. Finally, what is the risk of developing spasms after acute symptomatic neonatal seizures? There were 3 risk factors: severely abnormal EEG, or more than 3 days with seizure recorded on EEG, deep gray or brainstem injury on MRI, and an abnormal tone on discharge. If you have all 3, the risk of developing was 57% for infantile spasms. And then this is another study that came out. I showed you that the GABA receptor has a chloride influx, which causes its inhibitory action. But what people don't realize is that for it to work, it needs what is called as a sodium potassium chloride cotransporter. But this transporter is not well developed in the first few months of life. And it rather uses this potassium chloride cotransporter, which actually makes the GABA receptor being excitotoxic. So therefore, can you block this receptor by using bumetanide, which is a diuretic, in a small dose, 1 dose, so that the GABA receptors, so that the phenobarb and benzos start becoming inhibitory rather than excitatory in the first few months of life. That's the basis of this trial. And with that, I'd like to thank you, and I'll open it for questions.
Yeah, thank you. It was a great presentation and a kind of a novel way of approaching the whole thing. So,
how do I get out? Can I stop sharing?
Yeah, you can stop sharing. And Vishal?
Thanks a lot, sir. It was a fabulous presentation. Absolutely stunning. We have a few questions which have been asked in the chat box, and I'll start with one of my own questions first. You mentioned immunotherapy in the form of anakinra and tocilizumab, which you use for fires and nausea. What's your experience with other immunotherapies, like with methylprednisolone or with IVIG, which is occasionally used?
No. Let me clarify. Sorry. The first line for fires and nausea is to use Solimedrol for 3 to 5 days. And we have published a paper that after that, rather than using IVIG first, use plasmapheresis first and then IVIG. The reason for doing that, if you use IVIG, and if it doesn't work and you go to plasmapheresis, all the IVIG that you have given is going to be taken away. So we actually do first alpha-methylprednisone, then plasmapheresis, and then IVIG. And if this doesn't work, then we start tocilizumab and or anakinra.
Great. Thanks for that clarification. Now there's a question by Dr. Joshi.
No, I think yes. I'll add here. Say, Dr. Kothari, you feel like after starting this the anakinra, your outcome has changed?
Yes. We have a paper which is coming out in neurology where we showed clearly that there was a cytokine storm. We did the interleukin and the cytokines, and they were high. And then all the drugs failed. We introduced anakinra. This was in a 9-month-old baby with PCDH19, and which was in fire/nausea because of vaccination. And the drug level, I mean, the interleukins, the cytokine storm reduced, the seizures reduced. We tried to come off the anakinra and it again came back. So we again used it for a few more days and then stopped it. And now the patient is only on Epidiolex and Fintepla for the PCDH19 and is doing quite well. So I think it has improved outcome when we use anakinra or tocilizumab.
No, that's a one-off patient or it is a group?
No. This is one which is being published, but we have probably about 50 patients at least. We use this. So we are an center of excellence for autoimmune encephalitis. So we get a lot of these status patients coming in, probably one per week. And we don't have some choices at some point. You know, when you give pentobarb and we use midazolam and nothing works, we do use anakinra and tocilizumab, and it does work in that situation. So I think it's something we always use. I prefer anakinra because it has lesser toxicity in the long term as compared to tocilizumab, but both of them are fine to be used.
Yeah, so how early you will use? Because we had some experience and our experiences were not that good, I'd say.
So as I said, so I'll give steroids first.
Mm.
Obviously, you've already given phenobarb and dilantin, and you've used all the drugs. Then you're using steroids, plasmapheresis, IVIG, one more steroid course. And if it doesn't work, you straight go to either anakinra or tocilizumab. Guided by
the first week or within the second week.
Second week, guided by interleukins. Because if your IL-1 is high, then use anakinra. If your IL-6 is high, then use tocilizumab.
Okay, so that's too early. Okay, I'll say that we have to use it in the second week. Okay.
Yeah.
Okay, that's good. Okay, Vishal.
Dr. Sanjeev, the next question is about the sigma-1 receptors. So Dr. Joshi has asked that sigma-1 receptors cause improved cognition and learning. So that means antagonism by fenfluramine can cause learning difficulties and cognitive problems?
As a secondary thing in Dravis, you can't use Fentanyl in normal people. You have to use it in the epilepsy population, where the sigma-1 can be modulated. As of now, it's only tried in Lennox-Gastaut and Dravis, and it has shown improved cognition.
Then there's a question that since the electrical seizures adversely affect development, so that means controlling the electrical seizures with anti-seizure medications would improve the developmental outcomes automatically.
That has been shown in that paper I showed you. Yeah. So in the past, we say, does it really help? Are the anti-seizure medications giving more side effects and should not be aggressively used? This paper has clearly shown that it does improve cognitive outcome at 3 years of age.
The next one is, did you experience any excessive hearing loss with bumetanide or any literature on that?
So this paper just came. Bumetanide has been in and out of the press and media and publications because of its side effect profile. It's a diuretic. It has those others, but it's a one dose. It's not like a continuous. It's 0.3 milligram per kilogram, one dose. So other than the diuretic effect, nothing else was observed in that trial.
And what's your experience with ketogenic diet in fires?
So it is an option we have used. So in this child, which you'll read in neurology, we put the ketogenic diet simultaneously along with the other things. And it should be at the end of 1 week, if it doesn't work, I mean, if nothing is working besides anakinra or tocilizumab, we are introducing ketogenic diet in it, and it does work, I think. So the ketogenic diet will work through the chloride channel of the GABA, causing more acidosis and increasing the GABA activity.
The next one, I think, will be more directed towards Dr. Vinyan. What's the status of clearance of stiripentol, cannabidiol, and cenobamate in India? So any of these?
I didn't understand the question.
It's more for Dr. Vinyan that.
Yeah. So for India,
what is the DCGI clearance for stiripentol, cannabidiol, and cenobamate? What's the status in India currently?
Yes, as far as I know, it is still not reached that level. See, the problem with this kind of drugs is it's not mass drugs. See, that is one issue with this anti-epileptic drug development. See, companies want mass drug which can be used across all types of population. And then for us in pediatrics, we have very complex epilepsies. We need those kind of drugs are very, very niche drugs. That's why this Sabril also took a lot of time. That vigabatrin took a lot of time to come to India because it's not a mass drug. So the problem with cenobamate, there is a chance. I think it will, as Dr. Kothari told, it is going through adult to pediatrics in the standard way. But as far as stiripentol and cannabidiol, the issue is the side effect profile, and then cannabidiol has got its own excise issues also for India, specific issues. So I think it will take some time. And stiripentol, the problem is it is not a new drug. It is a very, very old drug. And it came, I think it is before topiramate. Even when I was studying, it was there. And it's not, I'm not very old, I'll say. But it will, minimum 20-25 years, this drug was there in the US, the European market. And the problem is it's a very, very bad drug as far as pharmacokinetics is concerned. And it has to be used with caution. And it's not a very mass drug. So it will come into Dravet. So if we, as a group, if we can push it through some patient groups, this will be the one drug which we can try, like what we have achieved in with Vagibatri now.
I mean, I can add two other points to that. And as you mentioned correctly, stiripentol, or dicomit, as it's called in America, was available in Paris for a long time. Their studies on Dravet were done in the 90s and early 2000s. So it can be brought into the Indian market if, on a compassionate basis. It's not going to be that expensive. Now, cenobamate is manufactured by a company called SK Pharma, which is South Korea. So it's again in the Asian continent. So it can be brought in through that route into the Indian market. That's just my opinion.
Okay, there's another one, Dr. Sanjeev, that in a case of fires where there's no elevation of IL-1 or IL-6, still you would urge to give anakinra or tocilizumab?
So the issue over here is that by the time all these cytokines come back to us a week or 2 weeks later, so we don't know the answer. We use it empirically. Even in autoimmune encephalitis, the same issues. All the autoantibodies come much later, so we use empirically if everything fits over there.
No, but again, for the crowd, I'll ask you at this point, IL-6, anakinra and tocilizumab is there in your pathway, the protocol. Okay.
Absolutely.
Okay.
There are plenty of articles which have come out in the market on this issue. Plenty of articles in the press that have come out on this issue. So almost anybody in any of the children's hospital in the US will use it. If you're almost liable if you don't use it, unfortunately.
Okay. What's your experience with DBS in controlling seizures?
So here's my take on this. We prefer RNS over DBS. Responsive nerve stimulation, the advantage over DBS is that it actually detects and then aborts the seizures. DBS just is like a VNS sort of a thing, but intracerebral. And so we have several papers which have come out on RNS use. We have 15 patients with responsive nerve stimulation in pediatric ages up to the age of 8 years. It's approved right now about 18. But if your bone thickness allows you can put the device, the battery in a skull thickness. That's basically the limiting factor. And they are extending their indication to pediatrics up to 12 years. We are one of the site. So in my opinion, RNS is better. And I'll just add one point on this. So in DBS, it's the anterior nucleus of the thalamus. In RNS, it's usually cortical or stereo EEG. But there is data now coming out that centromedian nucleus bilaterally, if you put the two electrodes on either side, you can stimulate both bilateral centromedian nuclei for LGS. There's a study going on in the US on adults with LGS with RNS using bilateral centromedian stimulation. So in my opinion, I'm biased, but my opinion is that RNS is better than DBS. And
Dr. Kothari, regarding this cenobamate, was it part of a clinical trial which you are using, or it was an off-label usage? Off-label. So what was the dosage you used? It is per kg, the pediatric dosage?
So, 200 milligrams, right? So if you extrapolate that in kids, it's about 3 to 5 milligram per kilogram.
So, but there is no data at this point. Clear pediatric data is not there.
No. The pharmacokinetic. So the way these FDA trials go on is they take the adult data and then they do like 25, 50 patients in kids to do their pharmacokinetic and pharmacodynamic study. And then they look at efficacy in another ones. And that's how the drug gets approved. That's how many pediatric drugs have got approved after adult exposure. So eslicarbazine, same mechanism. They use the adult data to get pediatric indication.
Once again, thanks a lot. I think since there are no more questions, I'll request Dr. Vinyan to please take over.
Yeah, I think it's one of the wonderful talks we have heard in the recent past, and I think it's a kind of a futuristic talk, I'll say. And we heard some specific drugs which we don't have at this point. Even anakinra is not in the market, in Indian market at this point. We have to get it on a compassionate basis at this point. But still, it is heartening to know that some new drugs are coming into this the bad complex epilepsies of childhood, and as a whole in the in the epilepsy literature, there is a lot of new drugs which are Dr. Kothari has clearly told that there are new drugs in the pipeline, and probably some of them will come, or it will come and go again. We don't know. Like this buvetendide, this Nemo trial came, and then it was a disaster, and now it is coming back again. So probably it will come again, and then we don't know. See, the main thing is a kind of mechanism-based therapy we might look at some point in time. So till then, it is a general drug, like we'll get more and more sodium channel drugs, but the sodium channel drugs are not bad. That is, again, cenobamate is a sodium channel drug, which has shown a very, very superior efficacy at this point. So with this, I think we can conclude, and over to the organizers for some.
I just want to add one. I just want to add one point. Lacosamide is still a great drug, and we use a lot of lacosamide, including the newborn period, because it's IV available. And eslicarbazine is another great drug. Those are two really good drugs, sodium channel drugs, which I think should be used more often.
Yeah, both of them are both these drugs are available in Indian market at this point, and we have IV preparations also. And even IV preparations of brivaracetam is also there at this point. So probably
that is also a great drug because it has almost 10 times faster penetration into the brain as compared to Keppra. So we use it more for our neurosurgeons are using it much more because for all TBIs they use Breviact over Keppra because it has within 15 minutes it enters the brain as compared to several hours with Keppra.
So your practice is completely Breviact has taken over Keppra at this point. It's just curious.
It depends on the insurance also. Some insurance will not cover before you have failed Keppra.
Okay.
But Breviac is superior even in efficacy because the SV it's more specific against the SV2A molecule.
And for Indian market, the good thing is we are getting all these drugs at a much cheaper price. Even we have some 45 brands of brivaracetam at this point in Indian market at this point.
Just to give you a cost point, Fintepla is available in the US market for $110,000. Clobazam, if you add to that, becomes another $30,000. And if you add CBD, it's another $30,000. So you're talking about $200,000 a year for these refractory patients to be used. And insurance doesn't always pay. Sometimes it pays and sometimes it doesn't.
Okay, we are lucky in that sense. So over to Kaushik.